Colorectal sessile serrated lesion detection using linked color imaging versus narrowband imaging, a parallel randomized controlled trial. Introduction. Colorectal cancer is one of the leading causes of cancer-related death worldwide. Colonoscopy remains the most important tool in the detection and removal of the precursor lesions of colorectal cancer. However, there is a reported adenoma miss rate of about 20% to 30% by conventional colonoscopy using white light imaging. In particular, sessile serrated lesions are more difficult to detect than conventional adenomas because they are often flat, inconspicuous, and covered with mucus. It has been reported that sessile serrated lesions may contribute to approximately 20% to 30% of sporadic colorectal cancers, and missed sessile serrated lesions during colonoscopy may play an important role in the development of interval colorectal cancer. These findings have underlined the importance of improving the detection efficacy for sessile serrated lesions. The developments in image-enhanced endoscopy technologies have allowed better diagnostic capability and improved identification of gastrointestinal lesions. Among them, narrowband imaging, NBI, is the most widely used modality, which exploits blue and green wavelengths to emphasize the capillary pattern and the surface of the mucosa, while linked color imaging, LCI, is a novel technology that relies on wavelength optimization of three colors, red, green, and blue, to make the lesions appear fuller. Previous studies have investigated the effectiveness of NBI or LCI in the detection of colorectal lesions in comparison with white light imaging, some of which have favored NBI or LCI as being superior to white light imaging. The author's previous study suggested that LCI could significantly improve colorectal sessile serrated lesion detection compared with white light imaging. There has, however, been no direct comparison between LCI and NBI for colorectal sessile serrated lesion detection. Whether LCI could serve as a more appropriate modality than NBI for colorectal sessile serrated lesion detection remains unclear. The present study aimed to compare the effectiveness of LCI and NBI in detecting colorectal sessile serrated lesions. The authors hoped to provide reliable evidence to guide clinical practice in the future. Methods. A prospective, parallel, randomized controlled trial was conducted. The participants were randomly assigned to the LCI or NBI arms. The primary endpoint was the sessile serrated lesion detection rate. Results. 406 patients were involved, 204 in the LCI arm and 202 in the NBI arm. The total polyp detection rate was 54.2%, adenoma detection rate was 38.7%, and sessile serrated lesion detection rate was 10.8%. The sessile serrated lesion detection rate was not significantly different between the LCI and NBI arms, 12.3% versus 9.4%. The differences in the detection rate and the per-patient number of polyps, adenomas, diminutive lesions, and flat lesions between LCI and NBI also were not statistically significant. Multivariate analysis showed that LCI and NBI were not independent factors associated with sessile serrated lesion detection rate, whereas Boston Bowel Preparation Scale score, withdrawal time, and operator experience were independent factors associated with sessile serrated lesion detection rate. Conclusions. LCI and NBI are comparable for SSL detection, as well as for the detection of polyps and adenomas.